This is a topic which actually is getting more and more attention, at least from my own perspective. And I did try to put this up question in the morning. SIG, those who were there, Dr. Soin was there, as to the concern which we should have when we have steatotic donors in this MSLD era. I made this program, I was expecting a surgeon to speak this topic, but the committee decided me to speak on it, so I'll just try and give you my own thoughts. So what are we going to discuss today? We're going to discuss about the characteristics of steatotic liver donors in context of MSLD, to evaluate the impact of steatotic donors on liver transplantation, suitability and outcome, and do we have some strategies which can say that yes, this is right and this is wrong? Are there any limits for steatosis in the donor? Now, fatty donors in liver transplantation, when we speak of them, we have liver steatosis, we have obesity, MSLD, and we have metabolic syndrome. So all these three things actually are there in a given patient. We have to address to all of these factors when a donor comes to us and has got fatty liver. And one thing which I must tell you, which one should be always alert, that liver steatosis is more accurately predicted by the visceral fat and triglyceride rather than BMI. So just that BMI is high does not mean that the liver is going to be fatty. Now, when we have a fatty graft, what are the issues which can happen? It can impact the recipient. There can be problem in the regeneration. There will be IR injury, both leading to graft dysfunction. And in the donor, there could be an issue with the functional remnant. We must be sure that the remnant which is there with the donor is adequate, is functioning well, and that donor can live with it in a normal way. And of course, the steatosis in the donor will again impact the regeneration. We should be aware of all these facts. Now, this is a standard which we all are aware of, that we have to have meticulous assessment of this liver fat. Liver biopsy still is gold standard, although we are doing it less often than before. But even with the best of MR, PDF which you're doing, I have seen that the liver adhesion index is often fallacious. It's not that accurate as I used to think earlier. The fibrosing cap values are also deceptive at times. And good quality MR spectroscopy is probably very good. But yes, we all are aware of a liver like this with more than 25% steatosis, which is primarily macrovascular, and it's a huge challenge for the surgeons, for the hepatologists and the entire team to select these patients, should we or should we not do with the donor surgery. So again, the issues in fatty liver donors in MSLD, what are they? We have three issues: donor liver fat, donor obesity, and a metabolic syndrome. Now, most centers use an upper limit of 10 to 30% of steatosis in various, permutation combinations. Data on microvascular steatosis is very little. It's the macrovascular which we normally talk about. And also a question which has always been discussed without a clear answer is, should we subtract the percentage of steatosis from estimated liver mass before calculating the final mass of allograft and the remnant? Some people would subtract, some centers don't subtract, but yes, it's something which we can discuss. And how would steatosis impact the graft? Now, there is a concern that steatotic livers may not function that well because they are more susceptible to general anesthesia and ischemic reperfusion, increased cold ischemic time, and impaired hepatic regeneration, because there is a reduction in the functional hepatic mass and some altered cell membrane fluidity. It can disrupt the microcirculation. So there are enough studies to say that liver with more than 30% steatosis, that is less tolerant to IR injury. More from the DDLT, data which we've seen, and our surgeons are very much aware of, often we have to take marginal livers in DDLT, but yes, we are more concerned with the living donor thing which we are discussing as of now. Now, what are the risks which we encounter in a patient who has MSLD, steatotic liver, and is obese? Well, we are all aware of these, the obesity classes, we are all aware, but there would be prolonged dissection time, blood loss, pulmonary complications, incisional hernias, wound healing issues, metabolic profile and all. So this is a very nicely and an elegantly done worldwide survey, which was published a few years back, of over 19,000 adult living donor liver transplants. And I think this is worth documenting here. How can it help us in our discussion today? So if you look at the center wise, the BMI acceptance, mostly, I mean, that's the proportion. Most people would go up to, 30 BMI, but there are some centers who can, go ahead even with higher BMIs without defined limit. Uh, what is the upper limit of macrovascular steatosis in donor? The blue bars are for the right lobe and the gray one for the left lobe. So mostly the right lobes up to 20%, I think centers are comfortable, whereas in the left lobe some would go up to 30%. Very few would go beyond that and say, oh, there are no limits. And of course, donor liver biopsy, whenever there's a need, it is done. But again, it again is center specific. I think that combination of BMI, elevated liver enzymes, and steatosis on imaging, all three are the most important deciding factor whether to do a donor biopsy or not. Some centers would follow a biopsy in any donor which is who is having a BMI more than 25 or 30. But again, this is not a practice which is universally followed. So, as I saw Nazia around, so this is a nice paper on a donor BMI, whether is it a contraindication, a BMI more than 30 for live donation. So they had 105 recipients published in AJT, BMI more than 30 versus less than 30. None of the donors had any problem. The similar post-operative complication rates, no difference in recipient outcomes, and generally if the BMI is high, but this graft is not steatotic. So I mentioned this in my earlier statement, just higher BMI does not mean steatotic graft. So if the BMI is high and the graft is not really steatotic obvious, then you can go ahead without a problem. Now, one more study which was published rather more recently, 66 recipients, this is from Johns Hopkins, 3 categories, BMI less than 25, 25 to 29, and more than 30. Generally no difference in the outcome across BMI. Higher wound complications in those who had higher BMI. Higher BMI group had higher wound infections, wound complications, but otherwise the length of hospital stay and recipient outcome were all similar. So just this was the thing which I wanted to highlight, that if you have a high BMI, perhaps your wound complications may be higher, is the local factors and all. So now the next important point which we have to address, so you have got a donor, has got a fatty liver, and is perhaps obese or a borderline obesity. So what we should do? The most important factor which I think has been addressed is lifestyle modification by exercise and diet. This has been emphasized again and again, and I will show our own experience also in this. So there are a couple of studies which have published this effect of diet and exercise, how it can impact the outcome and how we can improve such a donor who had a steatotic liver and that can improve subsequently. So this is a study which was from Medanta. I was there. This is a very nicely done actually study, 15 liver donors with steatosis who had paired liver biopsy. Now there's a combination of lifestyle modification, recommended calorie 1200 per day, and a minimum of 60 minutes of cardio training per day, exercise per day. And you look at these 15 donors. Now look at this. This is very interesting actually. So the first biopsy, the fat was anything from 15 to 25%, and except one patient, which was patient number 12, all of them had a reduction in steatosis on biopsy. And this is again seen, blue is the post-biopsy, post-exercise, post-intervention weight loss, and the fat on biopsy, and green is the pre-intervention liver fat. So significantly reduction, and you would see that 14 out of these 15 could actually undergo liver donation, and they had good outcomes. So this is quite interesting. But what is more interesting is a short paper from Korea and in Annals of Transplant. But what is unique in this paper? Here they had considered donors who had steatosis more than 30% on biopsy and BMI more than 25. Usually we would not accept such donors to start with. They say, no, you're not really suitable for this. So they worked on a weight reduction program, and what they showed was that the transplanted graft recipient and outcome was pretty good, and no difference in graft survival, although the numbers were very small. Nevertheless, it merits discussion. All they did was 5% weight loss, 1.6 kg per week for 8 weeks, and a paired biopsy was done. And look at this. So steatosis from first to second, 35 to 5%, this 30 to 10, almost, and in one patient, 70% steatosis. I don't know how they would have done that, but still, it is a published experience and, perhaps true for that population. But the point which I'm trying to emphasize is that if we have such donors who have steatotic livers, the thing which will really work out for you is an exercise and dietary regimen. I think that's the best as of now. Now, this is again something which we had discussed in our previous meeting, which published from ILPS. I don't really agree completely to this paper, but yes, I reviewed this also. What they showed that out of these 410 donors who were subjected to surgery, NASH was diagnosed histologically in 17 donors, and 4 were rejected, and 13 donors were considered subsequently. They had interventions, again, lifestyle changes, dietary modifications, and weight reduction more than 5%, and they showed reversal of NASH in these patients. So obviously, well, the slides are pretty much impressive. You can see this fat here, which has gone. This is fibrosis you can see here, F1, F2, which actually subsequently has almost disappeared. And then these donors subsequently donated. The only thing was that the bilirubin was little higher in those who had NASH pre-intervention, and the AST was higher. But ultimately, the recipients and the donors had a rather uneventful outcome. And the authors try to convey that, yes, even in NASH, you can sometimes select these donors after a very careful assessment. Although this is not something which is practiced across, because if somebody has a NASH proven on biopsy, has got F1, F2 fibrosis, I would not take that such donor for donation further. Because the question which I was discussing in the morning was that we still don't know what is going to happen to that particular donor who's probably in his 30s or 40s, young age. What will happen to him after 10 years, 20 years, 30 years? We don't know. So therefore, till that long-term profile or long-term outcome of donor is available in a strong database, we are probably not correct in taking these patients who had a biopsy with NASH in the very beginning. So next issue which we have to discuss is, this steatotic donors, obese. Can you do something? Well, besides diet and exercise, you can probably start using this newer drugs. Luma has fantastically, shown 2 papers consecutively, one on tirzepatide, which has been published in NEJM, 20% weight loss on a 15 milligram per day dose. Very impressive. And SGLT2 inhibitors also, people are trying. But the point is that, are they sufficiently strong enough to be recommended? I don't think so at this moment. Now, you can have some bariatric interventions. We had a lecture by Dr. Nijhavan today. Can we use some bariatric intervention to reduce weight and fat in these patients? You can have balloon, you can have GJ bypass. And I'll just show this one, yeah. So this is an interesting, case series of 4 patients. All of these 4 patients had some sort of bariatric surgery, mostly laparoscopic sleeve gastrectomy in 3, and one had got a gastric bypass at some time previously, and then subsequently the BMI improved like significantly, 30 to 21, 40 to 35, like that, and then they were taken up for living donor surgery. So there was a hint that, yes, you can use donors with the previous bariatric intervention, but again, this is a point to be discussed. So the important point, probably my surgical colleagues would sort of give more opinion on this point, that donor livers with up to 20% steatosis on the right lobe and up to 30% on the left lobe, without any inflammation, without any fibrosis, can perhaps safely be taken for donation, provided, please note, provided the GRWR and the future liver remnant are adequate, and metabolic syndrome is well controlled. So there are a lot of riders to this. One would like to, I remember a talk in few years in the INASL with a very good surgical colleague of mine, where they said only 10% steatosis I'll accept, beyond 10 I'll not accept. But I've seen that in practice we are taking more and more. We are taking 10, 20%, So what should be the actual guideline which we can tell to the audience? Whether left lobe higher fat can be taken, again, maybe my surgical colleague can be more authentic in telling me on that, what's the right thing to do. So as an algorithmic approach, if you have a steatotic liver with MSLD, what one should do exercise, and some drugs may or may not benefit, reduce steatosis, reduce weight. Diet, yes, it does help. Bariatric intervention, probably we are not following this part of the algorithm as of now. But yes, what really will matter is exercise and diet at this moment. Perhaps some drugs can be used. So to conclude, it is important to understand the impact of MSLD on liver donation. More than 30% steatosis or metabolic syndrome, which is fluid, they are at high risk. Moderate to severe steatosis impacts negatively on liver regeneration, and highly steatotic livers are more prone to IR injury. BMI more than 35 is generally relative contraindication. Right lobe plus versus left lobe, I have just mentioned the steatosis one may accept. And lifestyle modification using drug and exercise is the cornerstone. But what is most important is that long-term follow-up of steatotic liver donors should be instituted to assess the potential weight gain and development of MASH. We don't know the data on this, and I think that we should take up as a part of an LTSI program that these donors should be put on a long-term follow-up, and what happens to them in the longer term? Are they completely safe, or are they at risk at some stage of their life? Thank you very much.